I'm certainly appreciative of the opportunity. I was invited, I guess, I don't know, it was a month and a half ago, I guess, when we first talked about using this opportunity for this monthly meeting of the Shenandoah Valley Tea Party for me to be present and to share some thoughts on the work of the commission that I'm currently chairing related to Medicaid innovation and reform. There's quite a bit of activity going on, and so that's why I'm pleased there are a lot of people here. And quite frankly, I know over the last several days there's been quite a bit of publicity and invitations for people to come. So I arranged my thought pattern a little bit differently after I became aware that there would probably be a large group here that not only would be interested in information, but also would perhaps have preconceived ideas about what they wanted to see happen and thoughts of their own. So I will not take the whole time this evening with my remarks. I have some remarks that I will make, and then I'd certainly like to have a dialogue again and have an opportunity for you all to express your opinions and thoughts in reaction to what I said, or as a part of what you've been thinking in relationship to what's going on in the process. Obviously, it's a hot topic. Healthcare is a very complicated issue for all of us. And for me, how I became involved is somewhat of a long story, but I want to give a little bit of background on that. Obviously, I've been in the Senate now for 18 years and have had an opportunity for a number of leadership positions. Looking at the Affordable Care Act and what the Obama administration, along with Congress, were able to pass, I'd have to say, in just stepping aside for a moment on that, perhaps there's no one in the room that would have done it that way had they the opportunity to dictate what would be included in that measure. I certainly would not have, and there are a number of things that I would like to see changed in terms of federal legislation at this time. And I think there's a lot of concern about that and the implications for that. But one reason that I am involved and fairly aggressive here in Virginia in making sure that we do something is that I don't think we can afford to do nothing. We can't afford to do nothing. We live in a country that, as remarks were being made in the introductory remarks, the Pledge of Allegiance, the prayer, we're recognized as a leader in this world. Historically, we have earned that designation as a leader in this world. And in many instances, we still are a leader in terms of what our citizens can accomplish and the things that we do on a daily basis and what we stand for, certainly. Healthcare, not so much. Healthcare has evolved into a very convoluted system that costs entirely too much for anyone, and I think, hopefully that's one thing that we certainly can agree on up front here, that our healthcare delivery system, certainly it embodies many of the facets of a free market system, but collectively it's a hodgepodge that is way too costly, particularly when compared with other countries that spend much less and have, in many instances, better outcomes. One of the things that concerns me, and I think it should concern everyone, the gross domestic product of this nation is not growing as quickly as we'd like to see it right now, but it's a huge gross domestic product. And of that, approximately, we're pushing 20%, I think it's closer to 19% right now, of our gross domestic product is consumed in the healthcare delivery industry or system. To put that in perspective, if we look at the entire defense budget for this nation, all of its ramifications, consultants, men and women on the front line, we're talking about 3% of the gross domestic product. So in other words, we're spending about at least 6 to 7 times more on health care as we are on defense. Now, for many, you would think, well, health care is not something that the federal government should be involved with to start with. And I've come close to agreeing with you. Had we not evolved to this point in time where we're at right now. But obviously, when we look at who pays for health care in this country right now, and Virginia is no exception, you'll find that between Medicare, Medicaid, and no pay, you've reached 70 to 75% of the health care coverage in this country. The other 25 to 30% is commercial insurance. Now, that just puts a few things in perspective. Several years back, I developed a speaking points, an itemized list of things that I thought we should be doing here in the Commonwealth to bring greater efficiency to our government while we provide better service. And it was called an Agenda for Reform. And it was subtitled, How to Save $1 Billion Without Really Trying. And some of the things that talking piece was looking at that time were monies that we spend because we basically don't have the ethical and moral underpinnings to behave ourselves and to conduct the affairs of ourselves individually, as families, and as communities in a responsible way. And what am I talking about? I'm talking about issues related to substance abuse, our state prison population, foster care, all kinds of issues that are relevant to the society that we live in that we in part as taxpayers pay for. So that is just a bit of the background of some of my thought process why I think this is an extremely important topic. Ed mentioned that I chair, I'm on the Finance Committee. On the Finance Committee, and why I tend to be in the eye of the storm right now, if you will, is that I chair the subcommittee in the Senate Finance Committee that's responsible for the budget for Health and Human Resources. Health and Human Resources takes in a lot of areas, but one of those big areas is all of our healthcare delivery system from a government's perspective, including Medicaid, including our health department, social services, community service boards, our mental health delivery system, all behavioral health, all of that falls under the purview of the committee that I chair. And as I look at that and see all the unmet need, I recognize that we're going to have to do things differently in the future. We're simply not going to be able to fund or provide the funding necessary to meet the critical needs. Currently, we're involved in issues related to, in the behavioral health arena. We have training centers in the Commonwealth. Now, some of this background, you might not immediately see why this ties in with where we are with the MIRC Commission, but it does. We have a lot of individuals in this state that we have placed in training centers long-term. We have 5 of them. They're pretty expensive to operate. We also have a number of psychiatric hospitals. We began institutionalizing individuals back in Williamsburg at Eastern State in about 1769, and it's pyramided in terms of the needs and the costs there. So that has to be addressed. We also have in our communities 40 of them around the state, community service boards that provide services for individuals that have lots of issues, behavioral health issues, intellectual disability issues, developmental disabilities in the community. All of those fall under the purview of this subcommittee that we have to find funding for. The Affordable Care Act, some of you still would like to call it Obamacare, and that's fine. I think the president made a mistake by thinking that it was okay to call it Obamacare, because I think really we need health care reform in this country. And I know and that politicizes it too much in my mind in terms of calling it the name of the president. So I think we really should focus on the need for affordable health care and focus on that rather than the president who currently happens to be president. Be that what it may, there are a tremendous amount of initiatives included in the Affordable Care Act. And the one that we're talking about tonight, of course, are the implications to Medicaid. Medicare is a federal program. Many of you perhaps are aware, familiar, and are patrons in the Medicare delivery system. Medicaid is a state-run program. As such, it's a responsibility of the state to administer it and develop policies as appropriate for the individual states. That is why, and I agree with the decision when there was hope that the Supreme Court would overturn the Affordable Care Act completely. They upheld it, but did overturn the provision that required the states to expand their Medicaid populations up to 138% of poverty. And that's the crux of where we're at right now. It is a state decision, and so we're wrestling with that. During this past concluded session, the 2013 session, it was debated significantly, and there are a number of underlying factors that caused us to come to the conclusion that we did. Significantly, you can't take it just as a void saying, well, should we expand Medicaid or it's inappropriate and we shouldn't. You have to look at the other implications of the Affordable Care Act, in that the monies that are currently or have currently been flowing to support our healthcare delivery system in the hospitals, specifically at this moment I'll speak to, have been cut away under the provision that the Medicaid expansion would pick up a lot of your indigent care. So a lot of the money flow that is currently in place to take care of individuals that show up in high numbers at our emergency rooms that the hospitals are required to treat, and I think we all basically agree that that is something that should happen in this country, that people shouldn't be left to die outside the door, but they do come in and they get excellent treatment. But we pay for that already. It's already absorbed in one way or another, and so but that revenue flow is changing. So we have, that's one reason why the hospital associations are screaming right now, because in fact one of the hospitals in far southwest Virginia and Lee County has already closed their doors because of the implications of the funding being cut off at the federal level in the manner that it was, and we haven't of course expanded Medicaid so that the people they're serving would have that ability to fund the treatment. What we decided to do, we couldn't come to a total agreement on how to proceed. We felt that something needed to be done, but there was concern about the Medicaid system in the Commonwealth, and many of us felt that reform was in order, and that if we accomplished the reforms that we delineated, and I put in budget language personally into the debate in the Senate, which became a part of the compromise language that was developed at the end of the session, which basically said we would charge the administration with a series of reforms. There were 19 of them, but they fit basically into three broad categories of reforms that we wanted to see happen. And then further, we would set up this Medicaid Innovation and Reform Commission that would have oversight to looking at the progress the administration was making on all of these reforms. We would evaluate those reforms. We would also provide a forum for looking at other opportunities for reform to make the system better. And so that's what this commission, we established the commission then in late spring, and I was selected to chair the commission. And then we began our work through a series of meetings, which some of y'all had an opportunity to attend. We also, and this was a first for the General Assembly with the internet technology, we set up a website they gave the ability for individuals to go on the website, and it actually works. It was you can go on the website and you can make comments, and we've received several thousand comments on that website right now already, and it will be ongoing. We're trying to, before our last meeting, we had kind of a close-off period there where we tried to reconcile the information and summarize the statements, and we had staff people reading all of the input. But it's a tremendous amount of input. We've also held several meetings, including one public forum where we had 150 people sign up to speak, and it was quite a day of testimony. There are legitimate concerns, and I know you all are well aware of them, and perhaps some of you all want to express yourself about some of the concerns that are inherent in the Medicaid program and the potential for expansion. We're also reviewing progress in other states in terms of what the other states are doing. I think currently 25 of the states have moved forward with some form of expansion right now, and the others, particularly in the South, are kind of taking a wait and see. There are a couple exceptions in the South to that, and another responsibility that I've acquired the last couple of years is have been active in the Southern Legislative Conference, which is the 16 southern states. We all like to get together because we kind of think alike most of the time. Well, at any rate, I'm the current chair of that group of the Health and Public Safety Committee. And as such, we've convened a couple of meetings, and we had one meeting in Atlanta where we had the various that I chaired, where the various states came in and shared information about what they were doing with their Medicaid programs. We had the leadership from Arkansas there specifically because they're working on an innovative approach, which in Arkansas, they had Republican legislature, Democrat governor, and they were at odds, which is kind of where we're going to be here, I suppose, here in a couple months. And they came up with a plan which essentially, there's more to it than what I'm going to share with you. It's a fairly complicated plan, but in part, they are applying for a waiver to use the money, the additional money that they would get from the federal government to underwrite a portion of the cost of providing insurance, a more commercial-like package insurance to these individuals at the lower income levels. And there are various iterations on that. We've looked at that closely. We'll continue. Iowa has come up with a plan of a similar nature that builds in a number of additional features that would require some skin in the game, if you will, for the participants in terms of making sure that they are working on preventive health care, as an example, and having to provide some nominal co-pays. Michigan has put an innovative plan forward, and I'm hoping over the next month and a half that we'll be able to share information with other states and getting input from our citizens to determine if there's an effective plan that we can go forward here in Virginia so that we can do it Virginia's way. One of the things that I felt was a mistake, you perhaps would disagree on this point, but we opted in Virginia not to establish our own marketplace, the exchange that's getting a lot of attention right now. There was federal money available for us to do it in Virginia, and we opted not to do that. At this point, even though there still would be some federal money available to help us underwrite the cost of putting our own marketplace exchange in place, our insurance companies in the Commonwealth are a little bit far down the road in terms of meeting the requirements of the federal exchange. Obviously, you recognize the problem, as they had a problem rolling that out because of just how large and complicated it was to try to do it for the whole country. While some of the states that did it on their own, Kentucky, as an example of that has their own system, is working fine, and people are able to go to the internet and enroll. On that point, and I won't get sidetracked because I'll try not to, unless y'all want to talk about it more. It's not directly related to the work of the MIRC, but in terms of that issue, you know, as we look back in the history of healthcare delivery and people buying insurance, how many have in the past bought your insurance on the internet? That's just something we didn't do, right? I think it's kind of a cultural shock to just expect that overnight all of us are going to buy our insurance, or not all of us, but everyone in need of insurance is going to go to the internet to buy their insurance. So I think one of the things that if you've been frustrated by the lack of the ability to communicate on the internet, if you've actually gone out there, recognize that the commercial insurance carriers in Virginia are developing packages. You can go to the Farm Bureau and sit down with an agent, just like you would have in the past, and they can go over what's available in the Virginia market and work the information up for you. That's kind of an aside, but it's one of those things. If we're stuck with the Affordable Care Act the way it is currently, we're going to have to address it, at least in the short run, so that we can accommodate the insurance that people need for healthcare delivery. Okay, just a quick few other thoughts here that I'd like to share with you. We've not made any decisions at this point on whether or not we should expand. And I want to share some of our findings here a little later in terms of where we're at with these reforms, because we actually are making good and tangible progress in the reforms that we've proposed, which, if nothing else, will provide better service for the citizens of the Commonwealth, and will save Virginia taxpayers a significant amount of money because of the fact that we're working on these reforms. We've not put it to a formal vote, and I don't intend to bring it to a formal vote. Under the provisions of the act that was passed last year, once the administration, the Secretary of Health and Human Resources, feels that the reforms have been accomplished, they are supposed to advise us of that and ask our permission to negotiate with the federal government for a waiver that would allow the expansion. Now, there's big dollars involved, obviously, and I think most of you are aware of that, and I can speak specifically to those revenue flows if y'all want to hear some of that a little bit later. Savings, there is a lot of potential for savings. Some of the savings, of course, you're taking out of one pot and putting it in another, but if we are to proceed, some of the numbers that have been worked up, like in the area of indigent care, if we were to at least 50% of the people that currently are serviced by indigent care, we would save $637 million over the next 6 years. The insured patients being treated by the community service boards for mental health and substance abuse services, rather than currently being funded almost exclusively by the state and local governments, we would pick up savings of another $292 million. One of the areas that is interesting as part of the proposal are state prisoners, which currently we fund their health care from state taxpayer dollars. If we were to expand the Medicaid, we would save approximately $290 million because they would, in effect, qualify for the federally underwritten Medicaid expansion. It's expected that if things came together, it would slow the growth in premium increases for state workers by as much as another $170 million. And then there are other savings and shifts that would account for another roughly $250 million. So you're talking about the potential for some significant savings, but you're also talking about a long-term commitment. The federal government's commitment at this point in time is that for the first 3 years, 14, 15, 16, those calendar years, that they would pick up 100% of the cost of the expanded population. Currently, the contribution that we receive from the federal government for our Medicaid enrollees is 50%. It varies among states, but in Virginia it's 50%. So when a lot of times when we talk about Medicaid, people basically look to saying, well, there are low-income people, some of them are just too lazy to work, and indeed, I'm sure there are people out there working the system. But we also provide funding for our state psychiatric hospitals, all of the people that you find at Western State and our other psychiatric hospitals across the state. 50% of the cost of operating those facilities is paid by the federal government. Also in behavioral health, for our training centers, for individuals that we try to take care of with state resources, with intellectual and developmental disabilities, and we have a large waiting list. That's one of the things that's on my mind right now. I would really like to be able to address that waiting list. We have individuals that, where mom and dad are the caregiver for their child, and that child may be 50 years old now, and they're in their 70s, and they have no relief from the daily care. And so those individuals could get services if we had the money. They're on a waiting list, and we have several thousand people on a critical waiting list now to provide services for individuals with intellectual and developmental disabilities. So that's a part of the thinking right there. Let me just share quickly some of the general things we're trying to accomplish with our reforms. And that really is where my focus is. I know there will be questions to say, well, where are you, Emmett? What do you think? Haven't gotten there yet, but there are some people that would say to you right now that they're absolutely opposed to the expansion of Medicaid. I can't say that to you because while I'm not in favor of expanding right now, I'm working very hard on accomplishing reforms and setting up a scenario where it will make sense for us to expand. We're working on modernizing the Medicaid program. We're working on new managed care contracts, behavioral health services administration, coordinated care, transitioning populations still on fee-for-service into managed care for basic health services, and transitioning all remaining long-term care services into managed care. One of the things that's not clearly understood about Medicaid is that Medicaid is one of the big funders for long-term care for our senior population, so that's one of the areas that we have to address. And where we're at with that right now, I'll get into the finer print right now, just quickly on some of the specific things that we're looking to accomplish in the short one. We've divided our reform agenda into 3 phases, and the first is pretty tangible and we're pretty far along with it. Individuals that are have reached the age where they're eligible for Medicare, if they're low income, those of you who perhaps are on Medicare now understand that Medicare doesn't pay for everything, so you end up having to pay out of pocket. You've got to have a supplement. So individuals at certain low levels of income then can actually get Medicaid support in addition to Medicare. In the past, since Medicare is a federal program, Medicaid a state program, if we did things to save money in that program, it all inured to the benefit of the federal government. We're working with the feds now on a dual eligible project, which is projected to save us in the range of about $50 million over the next 2.5 years, where we can basically control the savings there, and the savings can inure to the Commonwealth of Virginia as we manage those people that have dual eligibility. Enhanced program integrity. We've developed a new data processing system that's pretty sophisticated, and actually I think Virginia right now is ahead of many of the other states in program integrity. What happens there? Not just individuals, but companies, businesses, you know, if they get a chance, unfortunately, that gets back to one of these things where when I was talking about the moral and ethical underpinnings of this country. If you didn't have to put in place safeguards so that your neighbor wouldn't rip you off, we could save a lot of money. And that's certainly one of the huge problems with the Medicaid and Medicare program, is that there are ways of scamming the system. And so we're working on program integrity to make sure that we don't have individuals and companies scamming the system. And that program integrity is projected to provide an additional $17 million in savings over the next 2.5 years. The foster care enrollment. Another issue related to the underpinnings of our society. We have a tremendous number of children in foster care. And obviously, you know, a child that has been taken away from irresponsible parents or doesn't have parents is a precious individual, it's a precious human life. And so we, as the state, have a responsibility to those individuals. So, but we, in the past, have not managed the care for these individuals. So we're working on that, and there should another approximately $14 million should be saved through managing care for these children in foster care. Eligibility and enrollment. I think that's probably a part of the issue relative to why the federal internet site isn't working well now, but in Virginia, we have a good system up right now for determining eligibility and reviewing that to determine if people really do qualify, if they really are at the low level of income and need the additional support. The access to veterans benefits for Medicaid recipients. Unfortunately, and this is a shame, you know, particularly as we're in a facility here utilized by our veterans. But we have so many of our veterans that are at low income levels and qualify for Medicaid in addition to veterans benefits. And so we're working on programs to provide managed care systems and data to effectively take care of our veterans that are eligible for Medicaid. Behavioral health services, this is a big one, and I've talked a bit about it, but a part of it had to do with upgrading our data systems to deal with that. But it's a big ticket item because we're looking at potential savings from this reform of about $135 million over the next 3 years. Commercial like packages, that's one of the things that I think is troubling to those of us and those of you who have to work for everything, and you're concerned about people who are not working as hard that might be entitled to benefits in a Medicaid expansion. We really believe that the Medicaid offering should be more like the benefits that you would have in a bare bones commercial insurance package. One example that I really don't like, if you have to go to the doctor, that's your responsibility, okay, to get to the doctor. It's your cost. If you are eligible for Medicaid, it's the cost of the Medicaid program for you to get to the doctor or the hospital. Now that may seem a minor item, but it can be significant. And I don't think it's an overimposition to look for those areas where we need to make sure the basic service is there, but we should not be in the business of creating a package that has more benefits than you would get through a commercial insurance package. Cost sharing and wellness programs, let me just quickly, I'm taking a little too much time here, so let me just quickly go through and bring this to a close so that I can hear from you on the comments that you might have. Cost sharing and wellness, limited provider networks, medical homes is a part of the reform package in phase one. Phase two, we're looking at incentives for companies to meet certain thresholds and targets for cost savings. We're looking at a number of pilot programs to try to get waivers with CMS, which is the federal program that operates the Medicaid programs. We're in phase three. We have a program which I mentioned just briefly, waivers for individuals with intellectual and developmental disabilities. We're redesigning our waivers. In many instances, the fee-for-service program that we have, we provide appropriate services, but sometimes it's in a package that's just totally costly, provides things that are not needed. So we are working on a redesign of that waiver so that we can provide services to these individuals in a more cost-efficient manner. And overall, in phase three, we're looking at more managed care. Now, one of the problems, of course, with managed care is if you don't have the appropriate management structure in place, you've got to manage the managers in managed care, or you can get ripped off. That's where you can lose a lot of your potential savings that can come with managed care if you have companies that are basically looking out for their bottom line rather than appropriately delivering the services for you. But that's one of the areas in phase three that we're looking at. And one of the big ones, of course, is long-term care, looking at coordinated care for long-term care so that we can recognize some savings in that arena. Beyond that, where do we go from here? I personally am meeting with a lot of people, hospital administrators, people involved with community services all over the state and in some of the other states to determine what they have that works, their concerns and ideas, so that we can put it into a broader based package. And let me just summarize where I think we're at here and where I think we need to go. As I mentioned at the beginning, I don't think we can afford to do nothing here in the Commonwealth with our healthcare system. What I would like to see us do, and I hope I'm in a position in middle to late December to roll out a package after bouncing it off of some of my colleagues and developing some things, which would be a Virginia Affordable Care Initiative, so that we can tailor some things here in Virginia that will be helpful in addressing not only the reforms that we're looking for in Medicaid, but also looking at the broader picture of healthcare delivery in the Commonwealth. We have a lot of healthcare providers in place. We have a safety net in place. Sometimes it doesn't work as effectively as it needs to, and certainly the cost drivers are in place that historically it's been escalating in such a way that we cannot continue, you know, this big to-do about people losing their insurance because the insurance that they had deficiencies according to the law. Well, that's going to have to be addressed and ironed out, but in many cases it's a sad fact of life with our current system, is that you think you have good insurance until you need it, and then it doesn't provide the coverage that you thought you had. And too many of our friends and neighbors who are hardworking, just don't earn that much money, have families to support, go through bankruptcy over relatively minor healthcare issues. So we're going to have to address that in some way. So I think there are a number of things that we can do, one of which doctors. One of the other hats that I wear is that I'm spending a fair amount of time on. I'm chairing the Center for Rural Virginia, where we focus on rural issues, what's going on in rural Virginia. Of course, this is rural Virginia, but we're fortunate that our economy is in relatively good shape here in the central Shenandoah Valley. But when you get to South Side Virginia, Southwest Virginia, Eastern Shore Virginia, where we have some real concerns with lack of employment opportunities and a lot of extreme poverty, where people are simply not able to afford even the basics of preventive health care and dental care. So those are some of the issues that we have to address. And I really believe if we address this total cost thing, I just scream. I don't know if any of y'all have had a CAT scan recently, but it shouldn't cost $2,000. And if it's going to cost $2,000, you ought to know right away whether there's somewhere else you can go and get it for $1,500. We need to establish a better free market for healthcare services in the Commonwealth and in this nation in order to help drive the cost of healthcare delivery down. I said we don't have enough doctors. One of the things we're looking at is the possibility, we actually are educating enough doctors in Virginia, but we're not keeping them because we don't have enough residency slots here in Virginia. So one of the things we need to do. And there's also a tip between the hospitals that are trying to manage everything and the independent doctors that would like to be able to just practice medicine in their own way without all this problem and big government, big bureaucracy looking over their shoulder all the time. Lots of issues there, and I know I haven't addressed everything y'all wanted to hear from me this evening, but that's a bit of it. And if y'all want to spend additional time making remarks would be fine. I'll take notes, or if you have suggestions, or if you have questions, I'll try to entertain them or get an answer to you if I don't have a ready answer. So thank y'all very much.
You mentioned the federal government. By the way, thank you for coming, and I just wish our national leaders were as well informed as you seem to be. So thank you. You mentioned the federal government for the first 3 years will do 100% reimbursement. What assurance do we have that they will follow through with that promise, since they seem to change things on the fly? And what will be their reimbursement after 3 years?
Okay. The first question, our federal government, in my opinion, and I expect you all would share this thought, needs to work on balancing the budget. All right. We're asking for that, we're expecting that, and I think we're going to have to soon start demanding that. One of the problems with that for Virginia is that we're very dependent on federal revenue flows already. As I mentioned, 50% of our health and human resources budget essentially comes from the federal government. My attitude toward that is there are 2 points. One, like it or hate it, under the Affordable Care Act, they defined a revenue flow to pay for it. Now, some of it are additional fees, taxes, shifting and funding mechanisms, but the money has been produced. Now, if you look at that pot of money, it could just fall into that deep hole of unfunded liabilities that the federal government has, and it wouldn't amount to a whole lot, but it was created to fund the Medicaid expansion. Virginia, as I might have indicated, could receive up to $2 billion per year for the first 3 years, and then it declines over several years to 90%, and then it will remain at 90% indefinitely. We put language in our budget bill and our statute that said if the federal government reduced their support for the program, then we would cancel the expansion of population. All right. Now we need, in my opinion, if we actually get to the point of actually moving forward with expansion, we need to work out a deal with the people who are actually working this program for us, that be the insurance carriers. And let me just clarify that. If in Virginia, we're looking at a system where the insurance carriers themselves would be providing this service and underwriting a significant part of it, not underwriting it, they get paid, but it's not like we're creating a bureaucracy that would actually be going out and doing all of this work for us. So I think it's reasonable to suggest and require as a condition that we would, of any arrangement that we had, contractual arrangement we have with the federal government, if we don't get that, then we reduce that. My opinion is that if the sun's shining today, you go out and enjoy yourself. If it rains tomorrow, that's when you have to do something different. So while the money is there, I think it's appropriate to use it, because a lot of the people, particularly the working poor that might be covered under this, are not going to be long-term beneficiaries. You only have an emergency appendectomy once, okay? And if you have the ability, you're only making $14,000 a year, and you've got a couple of kids, and you don't have health insurance. If you have that, and you don't, the hospital will end up paying it after they force you into bankruptcy, but they're going to force you into bankruptcy trying to collect. So that's probably a longer answer than you wanted to be, but that's the essence of it. I think we have to put safeguards into it, and we have to recognize that we already are up the creek if the federal government reneges on their responsibility for programs that are already in place. Our healthcare, our health department, many of the programs, other than public education, K-12 education, the federal government has very, very limited funding for that, and they try to exercise total control. So that's an area where we have a problem. But otherwise, we've got huge amounts of non-general funds flowing to the federal government. So we really need to make sure they get their budget house in order up there, so that they don't backtrack on the responsibilities of funding the program.
I think that you're absolutely correct. Reform is necessary. We have painted ourselves into a health care situation that's no longer sustainable. Congressman Bob Goodlatte said just today that he is committed to health care reform, and he's also committed to the overturning of the Affordable Care Act. And I think that there may be some interesting new ideas coming out of the House of Representatives going forward that might be prudent to think about and consider. I suspect that there's not going to be any reform. I listened to your numbers about the savings and the savings and the savings, and certainly we were told the Affordable Care Act was going to accrue incredible savings because I'm not sure why. And you talk about savings. But I think you cannot mention a single program where savings really did, in fact, accrue. And for instance, one of the things that Bob Goodlatte mentioned just today is that between 1960 and 2010, the Medicare program is now servicing 2.5 times more people today than it did in 1960. And the cost is 500 times greater than it was in 1960. And I couldn't parse all of your numbers pertaining to savings, but one number that particularly caught my attention was the idea that we could save $17 million because we manage foster child care services better. And I don't know what you mean by that, but I would ask, Have we not been managing it? And I ask that in particular because just today, I happened to read an article about an 11-year-old foster boy chained to a porch, discovered by a sheriff in North Carolina in response to an animal complaint. He had a dead chicken tied around his neck. But interestingly, his foster mother was a supervisor of social services. Now, obviously they need to manage foster care services better, but there's so much that government just is not doing well, where we talk about the numbers before the fact, but they don't happen. And I guess in conclusion, I would say in general, until we can come up with a system that combines something analogous to health savings accounts with catastrophic insurance and make people responsible for shopping around and seeing if we can save $500 on the MRI, for example, we're not going to save anything. Just coming over here, I just thought of something else. I was listening to NPR, and I actually thought of one more thing. Listening to NPR say that immigrants, legal immigrants in the United States from Russia, are obsessed with name brand pharmaceuticals, and they're entitled to Medicaid services, and they pay $3 copay for a generic or $6 for a brand name, which costs 10 times as much, and they insist on the brand name. And finally, pertinent to the non-functioning website and Medicaid, as I understand it, legal immigrants in this country can apply for Medicaid through the federal website. And there is a program, I believe, or a database called SAVE, which matches those legal immigrants with people who actually would qualify for Medicaid services. But even if the feds don't find that applicant in the database, for example, maybe it's someone from Al-Qaeda overseas, just playing games, they go into the database, and it's then incumbent upon the state to prove that that applicant was illegal, pull them from the database, and make sure that person never gets benefits that he in fact is not entitled to. And all of those things just make my eyelids heavy.
And I'll try to respond to briefly, I know we get a lot of questions. And I'll go from the last one first, I guess. That should not be able to happen in Virginia. We actually approach that from the reverse direction in terms of making sure that illegal immigrants are not entitled to those types of benefits.
No, this is not illegal. This is legal but non-citizen.
What you were insinuating there, though, is that they may be illegal, but it was going to be, they were going to treat them as legal until we verified the opposite.
Yes.
Okay. What I'm suggesting is that would be a part of our management system in Virginia, that would perhaps not be able to happen. There's no question Medicare has grown exponentially, but you know what? Medicare actually is a very successful system. It's paid, you pay for it. You paid for that. So you don't have to feel like you're getting some social welfare program getting Medicare because it's deducted from your wages, so it's paid for. The only item that kind of blew the budget a little bit, and we're kind of getting used to that, is Medicare Part D, which President Bush kind of snuck through there. But the other is paid for. So the reason why it's grown exponentially is because the population over 65 is growing exponentially now, and it's a good thing we have that system in place right now, or we would be in a world of hurt, because I think that program is functioning relatively well. It has issues relative to the integrity of the program, where companies have a tendency to skim some things there that they shouldn't, and it will need to be kept under control for the future. A foster child in North Carolina, I'm glad that was North Carolina. Okay, we can't take responsibility for what goes on down there. Indeed, you'll find terrible things like that happening with real parents and their children everywhere in this country. Goes back to our ethical underpinnings. Who would think of doing such a thing to a child? But what I would suggest in the area of how we save money in foster care, one of the things that I'm pleased to have been a part of over the last several years, we have in Virginia what's called a Comprehensive Services Act. Some of y'all may be familiar with how that operates. It's a state-local program where you deal with youngsters that have issues, and many of them are foster children. It's not uncommon, has not been uncommon in the past for one of these children that had some type of behavior that was uncontrollable to be placed in an entity that would charge the state and the local government up to $200,000 per child per year. We have been, over the last several years, working on programs to take care of those individuals in community-based settings in Virginia, and with wraparound services to deal with those children, whether they're foster care or not. And we've been able, over a 3-year period, to save real savings, I would suggest, of about $100 million. So that's a part of it. You have to develop a service for the child that's cost effective and not just do the easy way. Well, we'll send them off somewhere and they'll send us a bill with a fee for service. It has to be managed. So I think we can make inroads, and I believe that $17 million that I quoted is a realistic number. And hopefully we can do even better.